Welcome, everyone, and thank you for attending this training on cultural competency and evidence-based programs sponsored by the Center for Chronic Disease Prevention and Control at the Maryland Department of Health. My name is Sue Vaith, and I'm very pleased we're able to bring this training opportunity to all Maryland providers and of evidence-based programs. And I thank you so much for being here. Before we get started, I'd like to go over a few items to let you know how to participate in today's event. Today's webinar is being recorded. By continuing to participate in the webinar, you're consenting to be part of this recording. You will have the opportunity to submit text questions to today's presenters by typing your questions into the Q&A portion of the control panel. You may send your questions at any time during the presentation, and we'll collect these and address them during the Q&A session at the end of the presentation. When it comes time to conduct Q&A, you may also click Raise Hand to be unmuted and ask a question verbally. If you encounter any technical issues, please use the chat feature to send a message to Hannah Harold. Hannah will be providing technical support throughout today's webinar. Upon completion of the webinar, we ask all participants to please complete a short evaluation. The evaluation should pop up automatically on your screen. The link to the evaluation will also be sent out in a post-webinar email. Certificates of completion are available for attendees of the live webinar being presented today. If you would like a certificate of completion, please complete the evaluation, at which point you'll be redirected to a form to request your certificate. Certificates will be sent out via email within 1 week of this webinar. Next slide, please. So this is a statement of our administration's, the Prevention and Health Promotion Administration's mission and vision. Next slide, please. I want to take a moment to let you know some of the resources we have available in our center to help you manage and sustain your programs. Aside from these trainings, we provide sister websites, the BeHealthyMaryland.org and Workshop Wizard. The Workshop Wizard is a HIPAA-compliant site that helps you to publicize classes, manage referrals and feedback to physicians, to manage data, and assist with billing for the specifically for the diabetes prevention program. Our center also provides periodic funding opportunities for evidence-based program providers, either to expand their programs or to community-based organizations to develop new evidence-based programs. We have a diabetes prevention network that meets quarterly via webinar and in person, and we're planning the same for diabetes management providers. We are going to make the recording of this webinar available on our Be Healthy Maryland Partner Resources page and in the help section of the Workshop Wizard. And I urge you, if you are not part of the Workshop Wizard and you have classes you'd like to publicize on the Be Healthy Maryland website, we would love to hear from you about that. If you want more information about any of these resources, please contact me at suevaith.org, sue.vaith@maryland.gov. Sorry, I gave you the wrong. sue.vaith@maryland.gov. Next slide, please. Now I would like to introduce you to our presenters, Dr. Olivia Carter-Pokras and Dr. Ana Marie Izquierdo. Dr. Carter-Pokras is a professor of epidemiology at the University of Maryland School of Public Health. Dr. Izquierdo is a physician and executive director at Care for Your Health Incorporated. We're very happy to have you both here today for this webinar and look forward to your presentation.
Great. Thank you so much, Sue, for the introduction. My name's Olivia Carter-Pokras. I'm a professor of epidemiology at the University of Maryland School of Public Health. And so we just have an important acknowledgments and disclaimer slide. This webinar was developed with funding from the Maryland Department of Health Center for Chronic Disease Prevention and Control. As you had just learned, has a lot of resources that may be very helpful for you in your programs. We are presenting some research that's been collected with data that was funded through a Patient-Centered Outcomes Research Institute Award, as well as the National Institute for Minority Health and Health Disparities and the University of Maryland School of Public Health. The caveats of those funders is to remind you that statements presented in this presentation are solely the responsibility of the authors, the two of us, and do not necessarily represent the views of the Maryland Department of Health, the National Institute for Minority Health and Health Disparities, or the Patient-Centered Outcomes Research Institute, its Board of Governors, or methodology committee. Next, please. So what is the purpose of us coming together in terms of this webinar? In a very short period of time, we're hoping to describe the cultural influences on health in various populations. We'll give you some examples of how these cultural influences can make a difference in terms of understanding your path forward in terms of chronic disease management and prevention. We're also going to identify barriers to treatment and treatment adherence among minority populations, and recognize some strategies for culturally competent care, as well as communication within evidence-based programs. Next, please. So during our short time together, we will be touching on barriers to eliminating health disparities. You're very familiar with several of them, but hopefully we'll expand the horizons and inform you of some that you may not be as well aware of. We're going to touch on the cultural health professions as well as the providers who engage in this arena, the challenges of cross-cultural communication, barriers that are amenable to intervention, as well as provide an opportunity for self-reflection about one's own beliefs. We're hoping that at the end of this webinar, we'll have an opportunity to do a short reflection exercise. Next, please. So Dr. Ana Maria is now going to speak briefly about evidence-based medicine.
Hi. I'm sure you know evidence-based medicine, how it is used, and it's more of a process than it is just a set of data, right? Evidence-based medicine is understanding the question you have, in our case, sort of the values and the preferences of the patient, then look at the evidence that has been gathered through clinical expertise and hard work in research, and then put all those things together, sort of, and come up with the best option for any given patient, right? So a lot of times we think that evidence-based medicine is about reading the New England or reading the public health paper and applying it. And it's not. It's more of a sort of process by which you integrate that evidence with your own experience and the experience of the patient to come up with the best plan. So let me give you an example. When I am being asked to design a program for 80-year-olds that are of Central American origin, and the data that is available to me is that of how do we treat a wealthy population in Massachusetts that's mostly around 40 years old, there is a piece of information that comes from that evidence. But the reality is that I need to look at the patient, I need to look where they're coming on, and I need to look at if that evidence really matches. So as we go through this, always remember that we're going to be presenting you the results of studies, but they need to be taken in the context of who are we serving and what is our experience and what's best to the patient. Next.
Thank you, Dr. Izquierdo. So one of the things that's important for us to talk about is the persistence of disparities. We understand you already are aware of the nature and extent of disparities. There are in many different ways, all the way from diabetes, mortality, new cases of disease, as well as eventually cardiovascular disease and other health disparities that exist. One of the overarching goals for Healthy People 2020, which are our national goals for disease and prevention for the nation, is to achieve health equity, eliminate disparities, and improve the health of all groups. So you know the statistics, particularly in terms of chronic disease. We haven't made much progress, unfortunately. Indeed, in some cases, we're moving in the wrong direction. Life expectancy has declined yet another year in our country. So what can we do to change this direction? address the persistence of disparities? Well, one thing that those who have been working in this arena have started to think about is that we need to rethink our approaches. Interventions and initiatives that target upstream factors, social determinants of health, show the most promise for improving health equity. Next, please. So what are some examples of that? Well, Healthy People 2020, again, our national disease prevention and health promotion objectives for the nation, includes high school graduation rates for the first time as a leading health indicator. So this acknowledges the importance of social determinants of health. And as you would expect, there is a difference in terms of high school graduation rates by race ethnicity. Our on-time high school graduation rate is still below the 2020 target. Next, please. Related to that, physical activity and obesity also vary by education and race ethnicity. For those with the lowest education, for instance, less than high school, they're the ones who are the least physically active and with the highest rates of obesity. We also see that certain subgroups of our population are more likely to have more people with the lower socioeconomic status. And so this also results in those disparities that we observe by race ethnicity. Next, please. Access to health services is also lower for persons with less education and/or who are uninsured. So this means that lower access to care. This also means lower socioeconomic resources that they can rely on, which makes it very difficult to not only detect having chronic disease, but also better manage it. For instance, in this example, if you take a look by insurance status, whether or not you have a usual primary care provider, those who are uninsured, only 43% have a usual primary care provider. Next, please. And related to that is access to preventive services. It also varies by insurance status. If you're uninsured, you're only accessing, it's 25%. 25% of those who are uninsured are currently up to date in terms of their cancer screening. That's very different from those who have public health insurance, which is 57%, or 62% of those with private health insurance. Next, please. So what are some of the recommendations to achieve health equity? Well, there are things that we can do in our day-to-day work, but also beyond that, because individuals and communities can advocate for political, social, and economic policies. For instance, you might have heard the efforts within the state of Maryland and our various counties for health and all policies legislation. The intent is to improve health for those who are most vulnerable and support health advancement in multicultural populations. We can also help in understanding the legal rights and obligations to uphold civil rights laws and disability laws, as well as advocate for enforcement of those laws. And at the federal, state, and local government level, we can, as I mentioned, adopt a health in all policies approach that ensures that health issues are addressed broadly. So for instance, when we have a new intervention, a new policy initiative in regarding to housing, recognize that this will have an impact in terms of health status. Same thing about transportation. If we're talking, for instance, expanding the Beltway is a hot topic in my neighborhood at this point. So what impact is that going to have on air pollution levels, for instance, and other aspects of our health status? So thinking health in all policies approach can be something that can be applied then for not just those things that are traditionally thought of as being within the health arena, but realizing that these other things that impact on our social determinants of health also have an important impact in terms of our health status. Next, please. So there are national guidelines that have been out for a while. These came out of the Office of Minority Health, where I used to work in the federal government. The National Cultural and Linguistically Appropriate, or CLAS standards in health and healthcare. The principal standard is to provide effective, equitable, understandable, and respectful quality care and services that are responsive to diverse cultural health beliefs and practices, preferred languages, health literacy, and other communication needs. Wow, it's a mouthful, right? But you see some important things here. One is that health literacy is considered as being an important part of cultural competency. Another piece is when we're talking about these standards, We're talking about services. So we're talking about more than what one individual can do. We're talking about the importance of organizations, sort of changing how they do things, improving how they do things, so that what is provided is equitable, effective, understandable, and respectful. And I think that line, respectful, that word is the most important of all of these words. Next, please. So when we talk about education on diversity in the context of program participant care, our aims are to improve communication. That really is the bottom line of what we're talking about in this entire hour together. This goes along from how we set our agendas, to how we gather information, to how we negotiate treatment or management going forward, as well as how we build the relationships with our program participants. We build upon their experiences and help them go forward in terms of their better management of their chronic disease. Part of that is expressing empathy for where they're coming from and self-awareness of where we're coming from. We don't just show up into a workplace or into our volunteer settings without having prior experiences. We bring those prior experiences into those settings. And knowledge and understanding of any differences between sort of our perspectives and the perspectives of our program participants. And the ultimate goal is to reduce health disparities. So some of the terms you may have heard are cultural competence, cultural safety, cultural sensitivity, cultural sensibility, cultural humility, multicultural training, structural competency, and critical consciousness. My colleagues like to think that we need to move beyond the term of cultural competency. The cultural competency sounds like you do this 1-hour webinar and you're done. We see this more as a lifelong commitment to learning and really using your curiosity to learn about the other person and how best you can help them. Next, please. So social determinants of health are a broad range of things that impact all aspects of our life. Everything from economic stability, such as employment and income, to our neighborhood and physical environment. So housing, for instance, is included in that, as well as transportation. Education, the program participants' literacy, for instance, and how we respond to that, as well as language. Food, we have many individuals who have food insecurity in our areas that we're working with. Access to healthy options also. So we've heard of the term food deserts, where you might find neighborhoods where have a lot of fast food, for instance, but not really healthy food options nearby. Community and social context is another social determinant of health. So it talks about the support systems that the program participant might have access to, as well as how they're treated by others, which could result in discrimination and in stress. And the healthcare system itself. So whether or not they have healthcare coverage, whether it covers specialty care, and what sort of coverage do they have for the various aspects that they need to better manage their particular chronic disease, as well as the quality of care that's provided. So all of these social determinants of health ultimately impact on various health outcomes, from mortality to morbidity, life expectancy, health status, functional limitations. Next, please. So when we talk about cultural competency, you notice that the focus, the emphasis is on the organizations and the practitioners. And so when we're talking about practitioners, we're including those who are evidence-based program leaders and managers and those working on evidence-based programs. So it's the responsibility of those of us who are providing the services to recognize where the individual's coming from in terms of their cultural beliefs, their values, their attitudes, their traditions, their language preferences, and health practices, and apply this knowledge to influence positive health outcomes. Health literacy is the degree to which the individuals have the capacity to obtain, process, and understand basic health information and services needed to make appropriate health decisions. Next, please. So as you can see, cultural and conceptual knowledge is an important aspect of literacy. And this is from the Institute of Medicine's National Academy of Sciences report on health literacy. This includes our concepts and our understanding of things like how to prevent disease and what's the difference between chronic versus acute. Next, please. So Dr. Izquierdo, I think you can start from here.
Dr. Izquierdo, I think you're on mute.
Sorry, me and unmuting don't get along together, clearly. So what I was saying is that when you start looking at health, a cultural competency, it goes, like Dr. Carter was saying, tied to the health literacy. And it is our role as providers, whether we are designing a program to serve a community or whether we are the directors of a community health center or whether we are the first line providers, to look at the care we're gonna provide as it relates to the literacy of the person we are serving. And a lot of times people limit that literacy in the sense of, can you read, can you write, can I give you a handout? But we should look at it in a little bit broader in the sense like Olivia was mentioning, which is the culture around which this literacy exists and the beliefs under which this literacy exists. So, how do we create structures that people can relate to, right? That make sense to them. And sometimes it's about the language. And I know a lot of you have worked around creating products that have a second grade language, which I appreciate very much. But it goes beyond that, right? What is the understanding of that population that we are serving? We start talking about prevention, right? About how do we, you need to go to the eye doctor to prevent from becoming blind if you have diabetes. Is that their understanding? Does even prevention be part of their beliefs? And it is important that as you lead these efforts, as you and your staff lead these efforts, you are aware of this in a continuous basis, right? Let me give you an example. I was in a meeting last week where we were talking about advanced directives and trying to figure out how to make that happen for a diverse population. And, it was interesting to see the participants that were trying to make this happen really not understand some of the cultural nuances of the population we were going to serve. So as you go, always please, the idea of this curiosity, I think if I want you to live is like, be curious about the people you serve. Be curious about how they understand the world and what their beliefs are, because it's gonna get in the way of you being successful or not being successful. And finally, for those of you who have ever heard me speak, in order to be curious, you need to speak a language that is common. And linguistic competency, I think, is one of the biggest barriers we have to accomplish this. And how do we approach this, right? And generally I hear these things like, well, but in the county there are 130 languages. Like, okay, well, I'm not expecting everyone to become suddenly competent in 130 languages. But if you bring that as you design your resources, linguistic competency becomes a big element of your design of a program. Right? So not only the curiosity to understand the population you serve, but the tools, which are the language, to ask the right questions so that you can understand that population. Next. So, in my personal experience as a physician, I just find, food labels to be an excellent example of, how we do not communicate at the same level, right? So we are asking our participants or our patients, depending on your setting, to count calories and understand these things. And we don't even ask if they understand basic number counting, or if we, you know, understand what a carb is. And I think one of the things that you need to realize is that sometimes the best gets in the way of the achievable kind of thing. You know, is your patient ready to understand? You know, do they understand? Do they know how to count to 2,000 adding up calories? Or are they in a place where you're better off telling them the majority of your plate needs to be green? And that's all the education you give them, right? So as you build programs, I'm not saying that everybody needs to hear your plate needs to be green, but there's certain groups where that will be so much more helpful to work towards their healthy behaviors than having them counting calories would be. And of course, if you are like preparing a webinar for university students, go ahead with the calories so that they can have a better understanding, but understand the population you're serving and realize that sometimes what you are used to working with may not be appropriate and helpful for the populations that you are trying to reach. Next. So I have this story to share with you. I am Latino, and you know, I speak I speak 6 languages, but Arabic is not one of them, and certainly I'm not very familiar with the traditions of the Muslim religion. So I was in my clinic one day, and this young lady comes in with a burqa all covered, and I'm like, oops, I'm not sure how I have to go about this. And her concern was one of a gynecological nature. So I was wondering, like, what do I do? What do I do? So what I did is just like, I want to apologize, but I'm not very familiar with your culture, so I'm gonna need your guidance. Could you please tell me what's appropriate and respectful for me to do and what you will feel uncomfortable? And that's how we did the whole visit. She guided me, and I would ask, is this okay? And she would say, this is okay, but if you did it this way, it wouldn't be okay. And it was such a learning experience for me as a provider. And I share this because it is not the expectation of us that work in advocating for cultural competence and linguistic competence that everybody will know everything about everyone and every single culture. What the expectation is that you'll be respectful and curious enough to ask the right questions, to make that person feel respected in who they are and where they come from, and for you to be aware of your own biases so that you don't bring them up front. Next. Another story to share with you. And it's not always about the culture, right? The underlying culture, the underlying beliefs, but the life. Like we're talking about the social determinants of health. I had this gentleman in his 60s come because he had a terrible headache. His blood pressure was over 200. And, you know, we had this conversation about the importance of taking medication and how important it was to lower his blood pressure. And I spent 20 minutes talking to him about taking medication. And like 20 minutes into this conversation, he's like, okay, who am I kidding? I'm not going to take this medication. And instead of like yelling at him and saying, are you crazy? I'm like, oh, thank God. Tell me why not. Well, it so happens that the medication that had been recommended for him was a diuretic. It made him pee. And he was a truck driver. So he was delivering things all over the city. And he's like, I just cannot stop every hour to pee. It's not going to happen. So, you know, we spoke some more and changed the medication so he wouldn't have to stop to pee, and still the blood pressure would be taken care of. The idea of this particular example is that cultural competence goes beyond sort of, you know, he likes fried chicken or he eats tacos. It goes to the understanding that these social determinants of health, these transportation, these jobs, these have so much more impact on the lives of people than anything that we can, you know, do in terms of medication. That unless we're open-minded to hear these things, to include these things in the designs of our programs, we will fail. And we will fail these people that need us the most. So just some food for thought for you to see how what Dr. Carter was saying in terms of, you know, social determinants of health and literacy, how they all blend together into particular stories, into particular lives. And they go from the science to the reality of the people that put their lives in our care. So next. I think, oh, so another comment. We design a lot of programs, and a lot of these designs come from sort of a state level or federal level, or looking at local level at how we do things, right? And sometimes we forget on those programs, as well-intentioned as they are and as based on science as they are, to include people's lives in them. So asthma is a particularly sort of poignant case for me, because, you know, it is truly difficult for people to afford some of these medications, right? And, you know, they do what they have to do. They do what you ask them to do. They go to the county's asthma program. They, you know, clean up and remove carpets as you ask them to. All these things that were in the program, they do. And then when they get sick, they cannot afford the medication. So again, you know, we design things with the science in mind, but then if we don't bring the social determinants of health, you know, some of these medications, particularly if they're no generics, cost $600 a month. You know, guess what? They're not going to be able to afford it. They're going to end up in the emergency room with an asthma exacerbation, and hopefully they'll survive it. So when we look at this, I think we need to be cognizant of these elements of care, and we need to advocate for them, right? We need to advocate to make sure that medications that are basic, insulins, inhalers, are affordable to all in our community. Because if that is not part of the work we do, and I'm not meaning that we can all solve all the problems of the world, because I know we can't, but we need to incorporate these elements inside of any program we design, because otherwise they will fail. You know, they will end up in the hospital, which is where we didn't want them to end up. Next. One final story for you. Culturally, a lot of Latinos believe that insulin makes you blind. And it is, you know, something that they share. Oh, they gave you insulin, you're gonna go blind, because I had someone that took insulin and got blind. So this is another thing that you need to incorporate, these myths that are community myths, and each community has a different one, right? Like Chinese communities believe that if you talk about death, you bring it about. So let's not do any care planning because I'll die because I'm talking about this. So each community, each culture has certain myths around health and healthcare and how to stay healthy. And it is important to understand some of those because you will need to incorporate them, right? So, you know, maybe you are developing a diabetes program and you want to make sure that you reach, or you're targeting a Latino community. Well, you need to make sure that you talk about debunking some myths, right? And it's not that insulin makes you blind, it's that by the time you need insulin, your diabetes is so bad that the diabetes is making you blind. So as you design these kinds of programs, you need to make sure that you understand some of these major myths that are not individual in nature. It's not one person came to me and told me insulin makes you blind. They're pretty spread throughout the community, so that you include them in your trainings, in whatever it is that you're going to provide, so that they are addressed in a meaningful way for your participants. Next. The last thing, and this is not a case, but it's the idea of a lot of particularly immigrant communities, but also communities of color that may not have lived here, came from the South, or even those that come here. There's a lot of natural remedies or traditional remedies that are very, they're spoken of, they're used, and I think we should remember to incorporate those. And the challenge with a lot of those is that when you're creating an evidence-based program, you know, let's say you're looking at chronic care for hypertension, right? And you are putting together an evidence-based program. Well, I can tell you, Latinos believe that garlic reduces blood pressure, okay? Is there any evidence? No. Which pharmacy, which company, which government will fund $1 million worth of research on garlic? Nobody will do that. We will never have evidence on the effectiveness of garlic in blood pressure, okay? It's not gonna happen. Now, I think you need to balance, right? Between, do I really need evidence in order to recommend this? Or should I address sort of culturally based remedies as a way to engage the populations I'm serving, and as a way to get buy-in for other things that are more evidence-based? So it's this idea of, I acknowledge your beliefs by saying, having a conversation about garlic, and then you acknowledge mine when I tell you that what you need is exercise and eating with less salt, right? So when you think about remedies and home remedies, and, you know, particularly those that are not costly, you know, it's not what Dr. Oz says in TV, but more the traditional that my grandmother told me about. I think acknowledging those home remedies or those traditional remedies is important in setting that relationship and that respect for who you are as a person, and you know, allowing them to feel more comfortable with the whole programmatic approach that you're having to some particular chronic disease. Olivia?
Thank you very much, Ana Maria. I hope you appreciated hearing some of her real life stories and suggestions based on that. The bottom line that we've heard from this is cultural competency is just curiosity. Just do not assume. We want to move from this unconscious incompetence more towards unconscious competence, that we want to use our instruction feedback from our program participants and move ourselves more to the process where we are more on more as a partner relationship, working together with our program participants. Next, please. So one of the things we had done along the process, and we secured funding from the Patient-Centered Outcomes Research Institute to bring together patients living with chronic pain from all over the country, and the reasons for that chronic pain ranged widely. We asked them, what do you think providers need to know in terms of this area of cultural competence? What do you think needs to be done in terms of improving their education and training so you feel like you have improved communication and better manage of your chronic pain? So we talked about many different aspects. One is what's important to communicate to each other. So be welcoming, be understanding, advocate for the patient, take them at their word, create a bi-directional understanding. Pain has different meanings, and to learn a little bit more about what does it mean in that particular program participant's life. What's important to know for cultural competence is talking about how does their condition affect their everyday life. Understand better about their particular background, consider your own privileges and recognize your own biases. Recognize that we each have our own cultural biases and experiences that we're bringing into this interaction that we're having. Also better understand insurance benefits and what it covers and what it doesn't cover. In terms of strategies that work, listen, ask the right questions, use that curiosity. Think about different things that could make a big difference in terms of they're able to participate in your programs. For instance, you need to provide childcare, or at least refer them to where they can get childcare. Balance plain English without dumbing it down. Consider your program participant as a customer. Eliminate those barriers to participation. Think about the whole body. Think more holistically about the person. And there are many things that could be done to sort of reduce some of those barriers, everything from considering blogs and other technology, at-home connections that may be able to support your programs going forward. Next, please. So we want to move more towards from this initial thought that people had of cultural competence is like you learn and then you're done, more to cultural sensibility, which is an openness to emotional impressions, susceptibility, and sensitiveness that relates to a person's moral, emotional, or aesthetic ideas or standards. It's interactional. If one is open to an outside experience, one might reflect and change because of that experience. So we would imagine that you yourself are going to learn through this process and you will grow through this process. Next, please. Because we're aware that we all come from different backgrounds, different experiences, and we do carry unconscious bias without even realizing it. So this unconscious bias, implicit bias, occurs within the general population as well as those of us who work in various services. It's this unconscious negative evaluation of one group and its members relative to another. It does not mean discrimination in the legal sense, but the good news, it's malleable. It can change in response to situational cues and norms. We can fix this. Next, please. And one way to do that is reflective learning. And this way provides us a deeper understanding of our own unconscious thoughts, attitudes, and biases. It promotes that self-awareness, confidence, and growth. And it serves as a tool to elicit ongoing change and improvements in both effectiveness and quality of our programs. This is something we as individuals should do as well as part of our teams. And it can build on that developmental process of reflective learning from everyday experiences. Next, please. So if you could grab a piece of paper and a pencil or pen and just consider these questions. Reflect on a time when you observed or you yourself participated in a time when unconscious bias of an evidence-based program provider impacted outcomes negatively. Whether it, for instance, the program participant stopped coming to your sessions, or the program participant was not following instructions, or just whatever the outcome in a way that you weren't expecting, you weren't hoping for it to happen. So think about a time when unconscious bias of an evidence-based program provider impacted outcomes negatively. Consider how the program provider could have acted differently. Imagine how you might behave under the same circumstance and reflect on what would you do differently next time in the same situation. So we're going to give you a few minutes to think about this. Hannah, what do you think? 2, 3 minutes? Looking at the time frame, what do you suggest?
Yeah, I'll say 2 minutes, and I'll give a 1-minute warning and a 30-second warning, and then we can start again.
That sounds great. Thank you so much, everybody. If you can grab paper and pen or pencil and just think about a time where things did not go the way that you think they should have gone.
All right, we have 1 minute left for your reflections. Thirty more seconds. All right, and that's time.
Great, thank you. Next, please. So hopefully you've come up with some examples where our unconscious bias as evidence-based program providers can negatively impact program participant outcomes, whether it's due to racial, ethnic bias, gender bias, obesity, disability, ageism, sexual orientation, religion, or language ability. Because of the way that we set up this particular webinar, we weren't able to do this as pairs as we were hoping to initially. So I'm just going to toss it out there. I'm hoping somebody will be brave enough to share the example that they came up with. Is anybody willing to do that?
All right, we have one attendee who raised their hand. So
Oh, thank you. Please, please share.
I'm going to allow them to talk. Linda, you are unmuted. Let's see, Linda, you may have your phone muted or however you've connected to the webinar.
Linda, we're not able to hear you. You can just type it in if you're having difficulty speaking.
While Linda types it in, let me give you an example. I was also thinking about programs. So I was invited to be part of a conversation on multicultural aging in the county where I work. And there was a big audience, but there were very small amount of Latinos. And we were bringing up the subject of why are Latinos not attending. And one of the things that I was thinking is like, well, in the brochures that announced the program, it didn't say that there would be someone interpreting or helping with the language barriers. And they really were not set for that. They were like a couple of people that volunteered because they spoke both languages. So I think if you really want to have people that have linguistic diversity attend your programs, how you gonna address language barriers has to be thought of upfront and not as an afterthought during the event. So that was just an example that came to my mind when I was thinking about this. Do we have Linda's comments?
No, not yet. I think we're having some issues getting them to come through.
Anybody else have any suggestions, any thoughts about experiences that you've observed or participated in?
Let's see, we have another hand raised. So Melissa, I set it so you're allowed to talk and you've been unmuted. You want to try speaking?
Hi, can you hear me okay?
Yes, we can.
The example I wanted to give had to do with a obesity program, and it specifically required, or at least the evidence-based program approach had to do with, and it's actually the direction a lot of states are going, which is to, tax those sugary drinks and one person actually pushed back and they felt like it was not really engaging the community that purchases those, that are directly and disproportionately affected by obesity because of those drinks. But what it didn't incorporate or include, that it's not necessarily that they're buying those drinks because they love those drinks, it's because that's all they can afford. And that 99-cent sugary drink may feed a family of 4 when you're making less than $13,000 a year. And so their question was, why weren't we going after the people who actually manufacture those sugary drinks and putting the taxes on them as opposed to the public who can barely afford to feed their family? So it was one of those things where it wasn't necessarily about ethnicity, even though, one could say that certain populations were more or certain demographics were more reflected than others. But it was definitely one of those things where the culture, despite its best intents as far as trying to make better outcomes, and we could definitely see that there was some positive outcomes from those taxes, it didn't, I don't know if it necessarily took those other things, those social determinants of health into consideration.
Yes, and actually, it's so interesting that you would bring that up. Olivia and I were in a conversation with a legislator regarding that same tax, and one of the things that came up is like, this is overtaxing the populations we are trying to serve, because a tax of, 10 cents, if you live in Potomac, is nothing. But a tax of 10 cents, if you live in Langley Park, is a lot of money. So it is, as we design this program that is meant to help these populations that live in Langley Park and are severely affected by this, we are inadvertently overtaxing them without, like you were mentioning, addressing other elements of access to affordable food and drinks. So great case that you brought up.
Thank you.
In our remaining minutes, does anybody have any other examples or any questions for us? Hannah, if you could move to the next slide while people are pondering, I can at least cover that. So the bottom line from doing this short exercise, it's something that we encourage you to take to your programs and work with your program staff. And if you can do it in, dividing people up into pairs so they can share together, and then you can share in the broader group. That way, for people who are feeling a little shy, they'll still have an opportunity to share their story with somebody else without having to necessarily do it with a larger group. But this will give you an opportunity to kind of reflect on and learn from each other what you can do to kind of overcome these issues. So broaden that mindset, because we want to avoid unintended consequences. We want to emphasize the growth versus the fixed mindset, because a growth mindset, we can overcome bias through practice. It's a learning goal. Fixed mindset is thinking that bias is a stable trait. It's not. We all bring our prior experiences to the workplace, to our volunteer work, etc., and we can overcome our previous experiences and our preferences and our unconscious bias. So aim for the learning goal, and I think you'll do well. Any questions or any other stories that came up from those of you who are on the call? Linda did pop up. She said, provider focus on PC or manual and not looking at people. One man did not return. His complaint was that the provider was not prepared because they looked at the audience. He was not present for the orientation. And Kathy said, this information is built on my recent training in motivational interviewing when working with clients. Exactly. Motivational interviewing is considered to be an essential component in terms of training and cultural competency for providers. Kathy goes on to say the want-need concept rather than my agenda taking priority. Thank you so much, Kathy and Linda, for sharing that. It's funny, we tend to fill dead space, and I've learned it's important to give the quiet and give the silence to let people step in. So please do step in. Linda also added something. She said, accents. It's good idea to ask people in advance if they do understand the presenter because of different accents. So our apologies for not doing that. Thank you, Linda. We're learning also.
Yes, thank you. I get in trouble with my accent, so I'll remember to ask that when I give a talk or when I give a class. That's a great point.
So Sue and Hannah, are there any wrap-up things that you need to do on your end?
Yes, so if we can just go on to the next slide. I want to thank both you, Dr. Carter-Pokras and Dr. Izquierdo, for this excellent presentation, and thank everyone for attending today's webinar. Once you leave today's webinar, you'll receive an evaluation on the presentation. We would really appreciate it if you would complete that to provide your feedback. We use that for future work that we do, or future trainings. You'll have the opportunity to request a certificate of completion upon submitting the evaluation. So on behalf of the Maryland Department of Health and our presenters, thank you very much for joining us today, and have a great rest of your day.